Welcome. Um, Thank you for braving the gridlock and venturing out this afternoon. I'm Harold Holzer. I'm the director of Roosevelt House, for those of you who don't know me. And on behalf, that wasn't a cue. And on behalf of Hunter College President Jennifer Rabb and our LGBTQ Policy Center Director, Erin Mayo Adam, who's out on maternity leave, I'm excited to report. It's a privilege to welcome you all to Roosevelt House. You may have noticed as you entered through the lobby, and if the door was open too wide, you may not have seen it, so take a look when you leave, a big photograph of Franklin Roosevelt negotiating his way down the front steps to get to the street in this building with a brace emerging from his trouser leg. It was taken by the Daily News, but never published because there was a gentleman's agreement never to show Roosevelt in a wheelchair or even with the braces showing on his shoes. And it's a reminder that while living here in this house for 25 years, actually about 13 years after he and his family moved here and moved in with his mother on one side of the house, FDR struggled with the paralyzing effects of polio. Utilizing what was a rarity in turn-of-the-century townhouses in those days, an elevator, to, after his recovery, beginning to negotiate around the building and regaining his confidence. So if you ever wondered why FDR is always pictured in an armless wheelchair, it's because that was the only wheelchair that could fit into the tiny elevator, which you can see when you go up for your reception afterwards. There is the elevator is named for the late Bill Vanden Heuvel, but it is the same elevator door that Franklin used. So in a way, infectious disease in the days before vaccines is part of the legacy and even the architecture of Roosevelt House. But more to the point of tonight's important discussion, which promises to be both informative and constructive, that legacy also includes how FDR not only fought his affliction, but went on to work that would define his presidency and define disability rights and many, many other things. And it's a moment when the precarity of protection against polio is even back, as we have read about water in the metropolitan area. So one of the words is vigilance that we'll be discussing today. That's why it's so important to have this discussion. I know President Biden has said that the pandemic is over, whether or not it's true, but some things are still looming and other things beyond monkeypox. So the panel you'll hear tonight boasts major experience and expertise, and it brings together leaders from the worlds of medicine, academia, advocacy, and government to consider policies and practices with the power either to help or hinder in the fight against the spread of monkeypox and future infectious diseases. I want to welcome back to Roosevelt House our guests. In some cases, welcome back. Certainly a great friend of Hunter College and a very good personal friend too, State Senator Brad Hoylman, the pride of Chelsea, right? Author of numerous bills to combat discrimination, including the ban on walking while trans and other important pieces of legislation, whose insight and generosity have been demonstrated at several Roosevelt House programs. I just want to tell you a quick story. Brad was here one day and met our finalist for a Rhodes Scholarship, Devashish Basnet of Kathmandu, Nepal. And Brad, I wanted to introduce Brad because Brad was a Rhodes Scholar from the the Kathmandu, you're trying to stop me from doing my punchline, but I'm not going to. He was from the Kathmandu of the United States. He was from West Virginia when he won his Rhodes. So he gave him wonderful counsel and calmed him down. The next day, Dave had his interview, and the day after that, he became a Rhodes Scholar, the second in Hunter history. So thank you for that, too. Before I introduce the rest of the panel, just a word of welcome and acknowledgement to Mitch Drazen for all the help you do in supporting us in our LGBTQ programs. Thanks, Mitch. Joining is Council Member Lynn Schulman, who so ably represents District 29 in Queens. Member of the City Council LGBTQ Caucus that has been so active in sponsoring bills to help address the monkeypox outbreak. We'll hear more from her on that, I'm sure. I've actually known Lynn even longer than I've known Brad because at one time or another, we both worked for one of the most famous and greatest of Hunter alumni, Bella Abzug. So to round out our expert panel, and I will leave some of the introductions to our moderator because I don't want to, I've done my political and friend acknowledgements. But we have Dr. Erick Eiting from Mount Sinai. We have Anthony Fortenberry from Callan Lord Community Health Center, and Dr. Julian Watkins from the New York City Department of Health and Mental Hygiene. So thank you all very much for joining us. The biographies in the program. To lead tonight's discussion, we're really pleased to welcome a true Hunter giant, really, Dr. Sarit Golub, Hunter College Professor of Psychology and Director of the Hunter Alliance for Research and Translation. Her extensive and extraordinary work on human behavior and the spread of HIV/AIDS made her a hugely important voice here at Hunter and in the media during the outbreak of COVID-19, and her advice was so important on the trauma in addition to the outbreak. In one of the first Zooms we did when we suddenly realized we had to revert to Zoom in 2020, Sarit helped explain how the lessons of the AIDS epidemic could inform us in dealing with the COVID pandemic. And in a Daily News op-ed, as well as on television, she made resounding calls for hope rather than fear. So perhaps we'll learn tonight that a similar message is applicable to the outbreaks we're facing today. So thank you, Sarit, for joining us, this time happily in person. Thank you all for joining us in person. There will be a discussion, a Q&A, and a reception upstairs to which Mitch and I invite you to partake. And with that, Sarit, over to you.
Thanks so much, everyone, for joining us today. And can I just ask you a logistical question? Are we still hoping for like a 40-minute conversation with folks? Okay, awesome. And I have some questions for the panel, and then we'll leave some space at the end for a Q&A, an open Q&A. And I'm very excited to moderate today's discussion. I know that the electeds are your peeps. These folks are my peeps, so we're all good. And just a note on language today. I'm going to be using the term MPV to refer to this virus in an effort to be consistent with and responsive to community calls for anti-stigmatization. The discussion today, what I'm hoping that we really get at, is considering the unique public policy challenges that were inherent in this outbreak, and specifically the issues raised for LGBTQ health, equity, and access more broadly, and the ways in which we can use our knowledge around this outbreak as a lever to build more robust public policy responses that address anti-stigma, anti-racist, and health justice goals more broadly. And I would add, in deference to FDR, anti-ableist forces as well. So I'm going to jump right in. And what I'm hoping this can be a little bit of a back and forth discussion as opposed to just to this, but I will ask for each of you to introduce yourselves a little bit in terms of sharing briefly a little bit about your unique role and perspective in addressing the MPV outbreak. Each of you has made incredibly important contributions in different areas to programmatic, policy initiatives, legislative initiatives designed to mitigate the negative impact of MPV on our communities. And I'm hoping you just say a couple of words about what you think your most important role has been in responding to these issues. You made the mistake of sitting next to me, Jillian. We're going to start with you.
Thank you. When I think about my role in the response at the health department for a place that has been the epicenter twice in the last 2 years, first COVID-19 and then MPV, I think my role has beyond policy, community engagement. I think it has been bearing witness. Coming from this intersectional. From living at the intersection of race, being a Black person, also of Latin descent, but also a queer identified person, having worked in the field of HIV and sexual health, I think part of what my role has been was just to bear witness of the experience and to bring the truth and to speak the truth from the perspective that I've been, to make sure that some of these more mainstream, commonly understood perspectives aren't the only ones. Because I think there's a lot of folks who are left out of the conversation, who don't have seats at the table. And I think for me, it's not to speak for the community, but speak from that perspective to make sure that we have a more rich understanding of the context that the folks that we're trying to serve are living in.
Hi, thanks. Anthony Fortenberry. I'm the Chief Nursing Officer at a community health center in Chelsea called Callan Lord. I feel very similar to what you just described, but I think also an important component of that are the operations that were needed to quickly respond and often, I think, reactively as opposed to proactively, which I think is where the opportunity here is to really build sustainable infrastructure. And I will add to that, I think, centering also healthcare workers, and in this experience, healthcare workers that were also identifying as queer in communities of color that were disproportionately impacted by MPV, also caring for the community. And again, we're seeing, with MPV as with COVID, putting themselves on the front line. And so also thinking of them as well. Thank you.
Thank you. Good to see everyone. Thank you again, Harold and State Senator Brad Hoylman. I really want to thank those frontline workers and the physicians. I know Lynn agrees that as a non-physician on this panel, it's sometimes intimidating to be with a bunch of healthcare professionals. But we try to do what the medical community thinks is best, and we work with the health department, both at the state and the city levels, to make that possible. What we didn't get in this crisis, and again, it was a movie repeating itself, was a real active engagement at the federal level. And frankly, I wonder what the hell Rachel Walensky was up to during the MPV outbreak, because she wasn't focused on our community. And, I think that has to be said, that there was foot dragging from the feds, and it led to, the state and the city scrambling. I think my role was really to kind of channel engagement from a lot of my constituents who were incredibly frustrated, worried, nervous, maddened by the fact that the vaccine portals didn't work, that there was seemed to be a lot of misinformation and confusion, and this kind of Hunger Games mentality that you have to have, the skill set to refresh your browser in order to get a vaccine appointment. And it shouldn't, of course, be that way. But what's so sad and frustrating is that's exactly what we experienced during COVID-19. And it's a shame that we didn't have our act together. I do put most of the responsibility at the federal government. I am proud that our local and state colleagues responded to the best we could. I know Lynn had an oversight hearing, which was really important. She organized the LGBTQ caucus, which seems about like half the council at this point. And not quite. We're working on that. We're working on that part. And I'd like to think that I and my colleagues, when writing to Governor Hochul, pressed her to call a state of emergency here in New York. So I think that was my input in addition to assessing, where we go from here. But thank you so much for having me.
Hey, my name is Erick Eiting. I'm an emergency physician by training. I work at Mount Sinai at the Icahn School of Medicine at Mount Sinai. I'm also president of the New York County Medical Society. And my roles at Sinai, the two I think most vital ones are I'm the medical director for quality for our Center for Transgender Medicine and Surgery. And I'm also the program director for our LGBTQ Medicine Fellowship. It was the first of its kind in this country, and it's a really amazing training opportunity. And I think the role that I was able to bring to this, it's certainly not unique, but I think that to me it was really important that we normalized the experience that our patients were going through, that we didn't create it as some sort of carve out, that we weren't creating this model of exceptionalism, and that while I think that there was an incredible role to have max vaccination sites in gymnasiums and public schools when we were responding to COVID, it was clear to me from the beginning that this was something that was different and that we needed to make sure that we put that lens on our patients' experiences. I mean, we saw very early on that 30% of patients who ended up testing positive for monkeypox also had some kind of concurrent sexually transmitted infection. And so to take that away and to not give them the opportunity to talk about that, to offer them testing if they were symptomatic, I thought was really important. And I'm very proud of the work that my institution has done and the fact that we have been able to incorporate that in what I think has been a more normalized approach to accessing healthcare. So we're certainly not done yet, but I think we're moving things in the right direction. Thank you.
Hi, I'm Lynn Schulman. I'm the council member for the 29th District, which takes in Forest Hills, Rego Park, Kew Gardens, a piece of Richmond Hill. By the way, I want to thank you for saying MPV because the World Health Organization, which is supposed to be considering changing the name, has not yet, so that's a problem. I am also the chair of the Health Committee, which I'm very proud of, and I've used that title and that position to really leverage making inroads in terms of MPV, in terms of hospital capacity, in terms of a lot of different issues. I want to tell you, I have devoted my personal and professional life to healthcare advocacy, which was born out of the AIDS epidemic when friends and neighbors of mine were dying because of the indifference of those in power. We saw the same thing with COVID. We saw the same thing with MPV. And it's not just, I want to thank my colleague, Brad Hoylman, because it wasn't just the federal government. This was the World Health Organization, which didn't recognize MPV for a while. It had been going on in Europe. They saw that there was MPV happening in non-endemic, which means places where it usually wouldn't happen, areas, and they were very slow to recognize that. The United States was very slow to recognize that. Unfortunately, we have a federal government that has a system that's very bureaucratic, and so we're not prepared for the next level of epidemic or pandemic, so that's an issue. What I was able to do in terms of being the chair of the health department of the health committee was I held a hearing, but separate from that, before we even did that, we had a forum. We had a town hall that the speaker of the city council hosted with me. We got all of we got a lot of CBOs. We got a lot of people involved, and I was working hand in hand with the Commissioner Vossen, in terms of what we could do, things that we can look at. I would get complaints from people. I would share them with them. We had a routine and we had a process where we got things done really quickly. I would get complaints. There would be complaints on social media. I would call his staff or call him directly and let him know. I asked the speaker if she would be willing to do what's called a night of action. We have never done that before. We worked with the mayor's office, Alliance, the Restaurant Alliance, and Nightlife Alliance, rather, all of them to identify LGBTQ venues where we could go and hand out educational materials, talk to patrons and all of that, and we did that one night, and it was great. We had a great response. Commissioner Vossen came out with me to Queens to go to the venues around in my area and So it was very important. It got a lot of play. People didn't know about it. We actually had people bilingual come with us in different languages. So that was really important. And we learned along the way. I mean, you don't know everything in the very beginning. And so, I want to thank the health department for their not only responsiveness, but their partnership and collaboration. And I also supported Senator Hoylman and his colleagues too in the Assembly, who, when they sent a letter to the governor, we helped to support that. And also, I sent a letter as the health chair to the head of the CDC, asking them for more vaccines. We have come together, all of us, to really help here. And I want to thank Helen Lord. I want to thank everybody, Mount Sinai, and because the other thing too is that people were contacting me who had monkeypox, but they went to their doctor and their doctor didn't know what to do. Their doctor had no clue. So I arranged I told the mayor's office actually that they had to make sure that people could call 311 if they needed care and to be given a referral. So these are the kinds of things that we often do behind the scenes, us as elected officials, but it's really important. And I want to thank Jennifer Rabb, and I want to thank Harold Holzer for holding this today, because it's very important for us to educate people and also to get information out there as to what's being done and what we're able to do. So thank you.
Awesome. So in listening to all of you, I heard two themes that came out across the different answers. One really had to do with sort of advocacy around voice, around lifting community voices up, about advocating for who should be listened to and who can become part of the conversation. And then the other thing that I heard a lot was this sort of tension that I think we experience between what I would call normalization versus exceptionalism. So an idea that, and this is something that I think we struggle with in HIV a lot, and I think it's something that we struggle with in sexual health a lot, and I think it's something that we struggle with in LGBTQ health a lot. How much do we say, no, this is different? And how much do we say, no, actually, this is very much the same? And so, I heard a lot of connections, a lot of connections to COVID in general, but there were ways in which I think that monkeypox MPV was different because it was primarily affecting the LGBTQ community. And so one question that I have for you is, how do you sort of balance that issue of exceptionalism versus normalization or universalization? And what does that teach us about how to better lift up the LGBTQ community in public health issues that are related to the community in general? That was a hard question. Anyone can jump in.
Well, I would say that, you saw during the kind of early stages of MPV that, we opened a clinic in Chelsea, which was good. But of course, we found out later that we were missing, more than half of the impacted patients in other boroughs. We kind of, it was a stereotype, I guess, in a way that kind of drove the conversation about white gay men, on the west side of Manhattan who were concerned and were alarmed and needed the vaccine. But we were leaving out a whole segment of the population. I think my takeaway there, framing it in the way you described, is that you need, the health advocates to be at the table to inform public policy decisions. Sometimes that doesn't happen, and it seems most times it doesn't happen regarding public health policy. Of course, we saw it in COVID and we saw it in HIV AIDS, but there was also the stigma, of course, associated with sex. And, talk about being sex positive. Well, this was like the opposite, the shame that was inflicted on so many people when they raised their hand and, wanted to get an MPV vaccine was really distressing. Or some trying to make it a political issue, calling it donkeypox, selling T-shirts online, and ridiculing men and others who were seeking to protect themselves, or others who very candidly described just how painful those lesions were and what they suffered through, and the harassment and trolling that was directed at them.
When I think about the community, I think that we, are exceptional. And I think that we carry with us that long trauma of the HIV pandemic. I think for those of us who are millennials, who may not have been of consciousness in the throngs or throes of the pandemic, a lot of us of the early days of the HIV pandemic, we carry that with us. The shame of living or coming to our consciousness before PrEP, pre-exposure prophylaxis, where there was the thought that you probably will end up getting HIV and dying from it if you're black or brown. But I think with that, our resilience that we carried forward, and the fact that we all had that, it felt like that, like with like some muscle memory almost, that we all snapped into action to really organize around this issue because it was so reminiscent of these other things. And I think the really important piece, one of the lessons that we should learn, that we have to take the time to learn because it's not going to come through osmosis, is the fact that we're overdue, as a discipline, public health, as medicine, we're overdue for a reconsideration of how we even look at the community. We saw in the early response, it's affecting the gays. Let's go to Chelsea. That's where the gays are. And that's not what it is right now. We live in 2022. We live in the 21st century. There's a lot more language. There's a lot more space and room for people to be more close to their authentic selves and understand what the community really looks like. And the LGBTQ community is not this monolith, but as a collection of so many beautiful communities with so much diversity in gender expression and identity, in sexual orientation, or in the structures that we build for ourselves. Living in these families, people kind of think of LGBTQ people as devoid of the family structure, but we have families. They are not traditional, as some folks may seem, but they're there. And I think we're overdue for this reimagination of what this community is. And looking at MSM, how does MSM capture all of this? Men who have sex with men. It's not enough, and the language fails us. And what we as a discipline owe the community that we're charged to serve is, it's up to us to make our language catch up. We shouldn't force people to be in these boxes or self-identify in these boxes because there's an act of violence to kind of shed a part of you that you fought and struggled so hard to become just to fit in the box so that you can get the thing, or to have to, it can be seen as shameful to, admit that, I may have anonymous partners, or I may have multiple partners. Some people have different perspectives or views on sex, and that's fine too. But I think that's one of the big takeaways. We're overdue for a reimagination and reevaluation of how we look at the community. And I think that there's a lot of lessons that we can learn from the community for how to be in community, how to be with folks across difference, and how to really support and stand in solidarity.
So I want to echo what Dr. Watkins just said, which is that we are exceptional, right? And I think it's important to emphasize that. But for me, I think what was really important was understanding that there are some pieces of this that are exceptional. And one is that we're an exceptional community. But part of it is that whenever you have I don't want to call this a novel disease because it's not new, right? I mean, we know that this has been around for 70 years or whatever it is, right? But the
novel presentation, let's call it that.
Yes, thank you. But so we knew that there was at least a new face to an old disease, and part of the process is you have to shepherd this to get to a place where it can be normalized, right? So in the very beginning, I think one of the biggest challenges is that you have something that shows up, it's a rash, and you're a doctor and you're like, I have no idea what this is. But the number of times that I've seen a rash where I have no idea where it was and we never figured it out, I mean, it's a number greater than 0, we'll say, right? So it's happened to me more than once. But to me, it's
upsetting. You do
That's a different panel.
Yeah. Yes, exactly. It is time to reimagine. But so one of the lessons that I learned in COVID was that COVID testing changed once we had developed our own internal test within our institution, right? And so I was able to take that knowledge and say, as soon as we saw this, like, I don't want to have to go and call the Department of Health and sit on the phone for an hour to get approval to test this and have a result that comes back in 7 hours. We now have an institution where, like, that's coming back in a matter of hours, right? And so, like, you have to have the champions there who are willing to walk this through and make sure that you can execute that.
I think that I'm glad you brought up testing, because that was the other piece, that in order to test, you needed to go through 100 and some odd pages with the CDC in order to do that. And so that was a problem. So that's why the declaration of a public health emergency by the state and by the city, and finally by the president, opened up some of those channels, opened up some of that procurement, opened up the ability to move forward a little bit quicker. And so, but those took time. Those didn't come until towards the very end. And, you mentioned about HIV and AIDS and how to look at it through that lens. I will tell you that I did have conversations with City Hall where I was told by some people there that they weren't looking at MPV through an LGBTQ lens. That was part of the problem of how they set up the people going online and not doing anything else and all of that. So I said, listen, there are people who don't have access to the internet, can't go online. So that's when they created a phone number. And, and I spoke to the health department about that. They created a phone number so you could call and actually make an appointment without having to go online. And they were all different. Actually, they're still working on trying to set up where you can make a preliminary, go up preliminarily and make an appointment. They also the CDC came up with this idea, and I'm going to ask the doctors to weigh in on this, about changing the way the vaccine was given so that they can use more of it in the vials, so that they had more of it to give and they can give the second doses, but they had to do it intradermal. And I know I studied this. So intradermal versus, is it subcutaneous? Am I correct?
Subcutaneous.
Okay, great. And there's a big difference in doing that. And when I had a hearing with Dr. Vossen, and I asked him, he said, oh, it's not that big of a deal. I said, when was the last time that you gave an intradermal vaccine? And he said, in medical school. So it wasn't that easy, and there are issues with it. But these are the things we have to look at. And representation, I want to just say something. Representation matters. It matters to all of us up here, because if I wasn't an LGBTQ person and I was chair of the health committee, we wouldn't have gone as far as we did. I'm very convinced of that. That's why representation matters. You have to have people LGBTQ in all different aspects of life in the city, because that's the only way we're going to move forward. That's the only way we're going to advocate for ourselves.
I'm going to put you on the spot a little bit in response to this as well, because I know that you speak really well about these issues. So what I'm hearing also is the distinction between playing catch up and leading with equity. And the word that I sort of wrote on my paper was nimble, sort of how can we be nimble? And I know that you have some experience in trying to create those systems. And so I just love to hear you talk a little bit about what do you think we need in order to do this moving forward?
Thank you. I do feel like we had a great opportunity with lessons learned from COVID-19 that we did not implement or institutionalize and kind of cement in our knee-jerk response to these kinds of outbreaks that will happen again and again. And I always feel like health equity considerations are always an afterthought in the way that we implement any kind of initiatives into the community. And like you said, where were the community advocates at the table? Where were all the stakeholders at the table to help inform our response? And it always feels like at the end of the day, whether it is, our, Black and brown patients or patients that are not consuming information in the same way. I always remember COVID-19 was happening for weeks, and a patient came in for their appointment and said, why is everything closing down around the city? They didn't have, the internet. They weren't watching the news every day. And so we have to, think about those patients. I always think about those patients when we're trying to do communications. Like, how is she going to hear this, right? And so really putting at the forefront these kinds of health equity considerations around who is creating the communications, how are people receiving them, and then what are people going to do when they do get that health information, right? Where are the resources that they are going to be able to access? Because we see, especially in the LGBTQ community, disproportionately are in the service industry, are in, jobs where they're not going to be able to work remotely or take the day off to go stand in line at the DOH. And so those are the kinds of concrete considerations that I think need to be at the forefront.
When we're thinking about what we can do differently, I think that we have a framing and an understanding issue. I think a lot of times we talk about health equity as this thing that we sprinkle on this program, sprinkle it on that program. We call in those folks, to do their mumbo jumbo and talk through these things when a problem has already been identified in the data. But when I think about health equity as someone who practices it, I look at it as an intervention, as a necessary intervention to counteract a lot of these structural and systemic norms that we have as a society, but as a discipline. And thinking about it across disciplines, not to just single out, but this is the public health panel, across disciplines, where we have this structural issue where if unchecked, the results are it's almost as if it's all written in stone already. And so I look at health equity as an intervention because we need one. We saw it in HIV, and we see it 40 years later, and now in New York City, men who have sex with men, black men who have sex with men, Latinx men who have sex with men, and black women who have sex with men are the three categories of folks who are diagnosed with the highest number of HIV of cases in the city, right? Not even talked about, not even imagined. But somehow, again, it always falls on these certain communities. And so looking at it as intervention, and part of a central tenet of health equity is race consciousness, right? The contemporary presentation of racism. How does it look right now? Because we are not dealing with 1960s racism. We're dealing with the overt things. There's hoods, there's people climbing on walls, in Washington, but it's like this covert thing, this way that we structure our systems, structure our institutions and our programs, where certain people are considered, certain people are an afterthought or not considered at all. And I think we need an intervention, and we need it so desperately. And these last few crises that have been stacked on each other just demonstrate how desperately we need it. And if we continue to operate in the way that we have been operating, kind of, this white supremacist capitalist structuring and framework, we're going to proceed without the full deck of cards, and we're going to find ourselves in this same thing again, and we're going to find ourselves gnashing our teeth and all of it, pulling out our hair to try to find how can we fix these things. And we have solutions out there. We just have to be humble enough to understand that there are different forms of knowledge, there are different ways to see the world, different ways to understand it, and engaging will make our responses better, will elevate the responses, will meet the standards of these communities that are quote unquote marginalized, right? And it will help us stop marginalizing them in our thoughts and in our policy.
And thank you for mentioning capitalism, because our healthcare system is driven by a profit motive. Even though you might work for a nonprofit hospital or health organization, and we saw that we basically handed over doses of MPV vaccine to our European counterparts who have a nationalized healthcare system and don't have the same motivation to stockpile vaccines that perhaps the United States has because of the profit margins that are at the top of the consideration. And we see it with PEP and PrEP. I mean, I have legislation that's actually sitting on the governor's desk waiting for her signature to mandate that insurance companies cover PEP and PrEP. But I think PEP and PrEP should be free for everyone. The costs, the co-pays associated with PEP and PrEP are still being imposed on on patients, even though they're not supposed to be.
And not to belabor the point, but I think it's really important that we pay attention to the information that's in front of us, right? I mean, like the first big article came out in the New England Journal of Medicine in July, and it talked about the experience of MPV between April and June. And one of the things that they highlighted in there was that 75% of the patients who had tested positive belonged to the white racial and ethnic category, right? And to me, it felt like an excuse for the medical community to say, sure, there's an inequity here, but it's really around the LGBTQ population. It's not about race and ethnicity. And yet here, we had plenty of data in New York City at that time that showed that we were having a very different experience. It was the Latinx community has been the group that's been the most impacted with the number of cases, followed by Black and African American, and then followed by white. So we can't ignore the information that's right in front of us. We have to make sure that we're still paying attention, even though we may have something that gets put out there that can act as a distraction.
There was a lot of controversy about whether or not MPV should be described as a sexually transmitted infection, and whether focusing on cases in a particular community or on demographic distribution is a correct framing or is a stigmatizing framing. And I just love to hear, how do you think about that decision, and how do you think this type of idea about naming and framing, like what are the values that we should be using in making those naming and framing decisions?
I'll start since I'm the health department guy in the room. I think that part of it is really understanding that there's different forms of knowledge. We have the data has its flaws. The fact that we have 5 racial and ethnic categories for all of humanity is absurd, and yet this is where we are in 2022. So understanding the limits, understanding that we don't do a good job as a society capturing sexual orientation and gender identity. We don't do a good job of really understanding, trans identity in many different ways. So there's that, knowing the limits, and then filling in those knowledge gaps, acknowledging that there are some knowledge gaps and that we have to look for other forms of knowledge. There's institutional knowledge. There is the lived experience. You have people coming from the community saying we need access to. At some point we have to listen, because you're going to be forced to. We've seen it over and over. Sometime you will, and I think it kind of comes down to, can we see the community as not just a problem, but as part of a solution? And it's a big shift. But what it is, it cannot be this thing where this hierarchical thing where we come in with our degrees and we're going to tell people how they can save themselves, when people have been saving themselves despite our expertise and the way that this country has so-called civilized them for so long. There's no integrity to even go in that from that stance. We have to really go in and look at the community as partners in this process, as people, as stakeholders, as people who can actually be a part of making this thing better and moving and bending and changing the reality that we find ourselves in. The solutions are out there. It's just we have to humble ourselves to go and ask them and listen.
I agree with all of that. I just wanted to also add specifically around, whether or not this is a sexually transmitted disease. We know that people, got MPV not through sexual transmission, but rather through skin-to-skin contact. And so I think it's a little dangerous to create that. I also am hesitant to I think we don't give our patients in the community the benefit of the doubt of the ability to understand the nuances. The complex things. We have to find a way to communicate in a way that people can understand and that they can give feedback to, and really partner with how we educate the community around things, because we're learning as we go too, as a healthcare community. And so I think it does need to be a partnership. And I think, creating, we need to trust our patients and our community.
I think the one unresolved issue in this whole, do we classify it as a sexually transmitted infection or not, is pediatrics, specifically adolescents, and the idea of consent around vaccination. So one of the challenges that we're still having is because it's not classified as an STI, then that means that in order to get vaccinated, if you're under 18, you have to have parental consent. And if you're under 16, that means you have to have a parent who's present who can sign a consent form for you. right? Which runs counter to the experience that we have with, for example, HPV vaccination, where we've said that adolescents have the ability to do that. So, I mean, the way that we define this still does box us, into certain decisions and certain options. And that to me is like, as we kind of move forward, I think that is a big piece that needs to be resolved, because, if we're making the decision, regardless of whether or not we're going to call this an STI, if we're making the decision that adolescents should be able to take charge of their own sexual and reproductive health, then we have to give them every opportunity, not just some opportunities.
Yeah, I think that's very interesting. In New York, we don't yet have the opportunity for young people to choose to be vaccinated without their parental consent. It's a huge issue in Albany. We've been basically tarred and feathered by anti-vaxxers since before COVID. I'm proud to have passed the bill that ended the religious exemption for vaccines of school-age children. But we need to go farther. I think we need to mandate the HPV vaccine for school children. I mean, it's a cancer vaccine, for God's sake, and it works. I'm very proud that our community embraced the MPV vaccine to the extent that it did. And I think, I ask myself, and Lynn, I'd be interested in what you think, since we're basically the same generation, what Larry Kramer would have thought. I think he would have said, tell them the truth, be candid about how it's transmitted, and, let people make their own decisions based on that. I don't know. You're looking at me skeptically. I think I'm your same
generation too.
Oh, okay.
I mean, Larry, I don't know how sex positive Larry Kramer would have been about this.
I wonder.
Because I worked with Larry Kramer at GMHC, at Gay Men's Health Crisis. So I think you need to look at, we're talking about theory and we're talking about reality. So, and you have to sort of look at both of those, so through both lenses. But so the reality is that a lot of the MPV infections were coming up in genital areas, if I'm recollecting correctly. So, that's the reality of it. And also, I have friends in the LGBTQ community who called me and said, listen, like this is happening at the sex clubs. We have to figure this out. We have to make sure that men are aware of this, so that that they don't maybe go with multiple partners and all that. And these are gay men who are very active, very sexually active, who have said to me, listen, we need to get it out there. We need to. So there's what you said. There's like maybe the stigma, but then there's also people that want the reality, which you were talking about.
When you operate from a heterosexist norms, we have different mores and social engagement and just different customs, and it's separate and something that should be studied, should be understood. We should be having this rich discussion about what does it mean to be LGBTQIA+ in the 21st century, and not compare it to heteronormativity. Let's let it be, and not have to be compared. And because again, when we look at humanity through such a very narrow and focused lens, again, we're operating from, it's so retrograde. It's not of the 21st century to look at humanity in this one. There's only one way to have a family. There's only one way to have sex. There's only one way to be a human. There's only one way to be this. It's preposterous that this is where we are in the 21st century. And that's why I think an intervention is so necessary for us to modernize this field. We have to rescue, we have to save it from itself, despite itself. And it's so urgent because the community trust is getting ticked away after emergency after emergency, letdown after letdown. And at some point, you're going to have, the Black community be like, 60% have mistrust of the system. And then people will look at the community saying, we don't trust you, and be like, oh, Tuskegee. As if all these failures and the lived context of their lives and the reality of them going to work and waiting in that line and going up to Harlem and seeing people who don't live in the neighborhood, as if that has no bearing. And so, we have to ask some really serious questions and take some really hard positions on where we go from here to modernize this thing. Otherwise, again, the cycle is going to continue.
I want to respect people's time and let you get at some point to the reception. However, we do have some time for a couple of questions from the audience. If there are, go ahead and then.
There's a mic.
Alexis is coming. Thank you.
Given the recent rise of culture wars and anti-LGBT hate spreading around right-wing media such as Fox News, as well as also major states pushing against LGBT rights such as Florida and Texas, how do you think this is going to play in whole of in monkeypox? Or rather, how is monkeypox going to play on whatever is going on?
I think the politicization of all of this, it just poses all kinds of challenges, because one of the things that we as the medical community are trying to counter is the stigma, right? And so it's like you have these opportunities that really just reinforce what you're trying to undo. So I just think that it makes it that much more challenging, you know, and I think the charge that falls to us is we have to make sure that, especially in communities where you may be outed or labeled as being a member of a certain community or engaging in certain behaviors, we need to make sure that we're putting the proper face on something, so it gives people the opportunity to still access everything that they need, but make sure that we're addressing their unique needs at the same time.
Did you want to respond? I'm sorry.
Just very quickly, Article 1557 of the ACA is being proposed changes right now from the Biden administration to amplify and protect LGBTQ discrimination. And so it's very important right now, if you're interested, to engage in advocacy around that to ensure that those protections are maintained in the ACA.
Dr. Watkins, you said, where do we go from here as it relates to public health equity? Where do we go from here? Because the HIV/AIDS epidemic didn't address people of color. Asthma rates in the Bronx are affecting people of color. Diabetes rates affecting people of color. COVID-19, people of color, and those disparities. And now MPV. It's going to keep happening. So at what point is knowing not enough? So where do we go from here?
Again, I think it's time for an intervention, you know, and I think we were up in the library and looking at these old books, you know, the playbooks that we have is like, we're like dusting off some dusty old thing that's sitting in the library written by folks who were deeply invested in white supremacy, imperialism, capitalism, and patriarchy, and did not make these structures for all of humanity. And I think it's time for us in the 21st century to look at these things that were handed to us. And, you know, it's going to bring up some pain. It's going to bring up some disappointment, some guilt, and all of that. We got to work through it. We got to take action and do what we have to do to live and let people thrive in this world so that we can be nimble, so that we can respond to whatever comes our way. And we have the tools, but I think it's like, do we have the will? Do we have the imagination to do what has to be done and move through the difficult part? Because it's going to be painful. June Jordan has this quote, "If you make my life horrible, if I get to tell the truth, it will be an uncomfortable truth." People of color, we're living with it every day. Everyone needs to know it's uncomfortable for us to have to live with it and experience it. You're going to be uncomfortable if you're from a more, dominant position. We're all going to have to sit with discomfort. That's just life. We got to move through it. Otherwise, same old, same old.
Question about the vaccine. I'm going to get these terms wrong, but the dermal and the subcutaneous, is there now enough vaccine for subcutaneous jabs to be given, and is one better than the other?
We have a national shortage. I don't think that we don't have enough to get everyone vaccinated with purely subcutaneous. And so this was a stopgap. So the intradermal, it's a full dose, but it just intradermal, the secondary mode of administration requires a smaller dose to get a similar immune response. And so that's kind of where we are now. Folks are still able to get subcutaneous because a lot of folks have certain conditions that would preclude them, or that they could possibly have a bad outcome from getting intradermal. Mostly folks, the newer mode of administration. We're not there yet. We still have a shortage.
What you just said?
We still have a shortage. We're not there yet. There's a stopgap for intradermal to get more folks vaccinated, but we can still do subcutaneous because a lot of folks cannot get intradermal for some of the side effects.
Follow-up question: do you have to be cute to be on this panel?
I think we have time for one more question. Yeah, here in the front.
Hi. So we saw the LGBTQ plus community organized during monkeypox, and we see how we have a lot of problems with our health systems, our underfunding of our health system, and not being able to pass the New York Health Act. What are avenues that you see that LGBTQ organizations can get involved with to push our electeds and our community to get more involved in helping the medical community fight for health equity and things that the community needs?
Well, I would say, we have so many important healthcare issues on the ballot in November: abortion rights, transgender youth, vaccine equity, just to name three. It's almost as if healthcare has risen to the top of the agenda, as it should, because we have faced a crisis for so long. I think November is going to dictate not only policy, but if the Democrats, God forbid, lose the House, you're going to have hearings about MPV, sponsored by the Republicans. You're going to have Tony Fauci, questioned by Jim Jordan. You're going to have a lot of nonsense about COVID and about reproductive health care and about issues that we as New Yorkers take for granted, which are going to be suddenly and I think starkly illuminated as political talking points for the Republican Party. So I would say that, vote in November like your life depends on it, because I think in many respects it will.
I think it's real, the charge is to us, right? I mean, like we really have to make sure that we don't lose this moment. And, I had early on, when we were still trying to get access to vaccine, and we saw the bulk of the infections of MPV were happening right here in New York City. The one piece of advice that I got was, don't spend as much time pursuing the advocacy channels through what you would think of as like the public health infrastructure, right? Use the LGBT advocacy channels. And to me, I think it was really great advice, but then, I feel like I sort of stood there wondering, I don't know where to go, right? And to me, I think it still falls to us in this community that we have to build that infrastructure, right? And whether that's community-based organizations, whether it's employee resource groups from our employers, even corporate advocacy. I mean, I think that we have to take advantage of every potential channel and build the right network so that when we are seeing something happen on the ground, that we know who it is that we can come to and we can use the power that we've created to advocate on our own behalf.
I think that's a beautiful idea on which to end. I want to thank everybody on the panel so much for these your amazing contributions, both in the world and also here tonight. And I think that what is particularly inspiring to me are the ways in which each of you spoke about what does make the LGBTQ community exceptional in advocacy and in vision around these issues. And I think that, Brad, one of the things that you were really speaking to is how can the LGBTQ community also lead in some of these, in the attack on all of us, that has been so focused on actually an attack on sexuality more broadly. And it gives me inspiration to work with all of you in that fight. So I would invite everyone to go to the reception and look forward to continuing the conversation. Thank you so much for being here tonight.